Autocoids is an pharmacology chapter which is important, especially in point of migraine and gout. So in this chapter we will be discussing about it, NSAIDs and all. It's a important chapter and it's also practically important for medicine point of view. So let's discuss autocoids. Okay, so let's talk about autocoids. I'm very excited for the session. Are you guys? So your excitation? 1 minute. Okay, so I got my pen. Actually, I went to grab the pen. Let's talk about autocoids. Autocoids is histamines and antihistamines. We are going to talk first. So histamines and antihistamines not that important, but it's better to know. So talking about histamines there are four types of receptors: H1, H2, H3, H4. But first, let me tell you that autocoids are acting hormones. Locally acting hormones. What they do is they act locally on that particular place. Okay, these are the autocoids. So autocoids are self-acting hormones. So these hormones have some receptors on different cells, right? So the receptors are of different types: histamine receptors, serotonin receptors, prostaglandin receptors. So histamine and serotonin, these are amine receptors. So if you see histamine has amine in it. So it is histamine receptor. So let's talk about it. So histamines, they have different receptors: H1, H2, H3, H4 receptors. So in H1 receptor, allergic manifestation. So let's talk about all the receptors separately. If you see H1 receptor is responsible for allergic manifestation and bronchospasm. So they're responsible for CNS activation. H1 blockers will suppress CNS. H1 blockers, they suppress the CNS. So if there is any H1 blocker, they suppress the CNS. So actually in CNS, what they do is, in CNS they increase the wakefulness. So the person is awake. If the person is awake, he will have more memory. It will increase the memory. Okay, but if the person is awake, it will also get vomiting. I mean, it's the trick to remember what on CNS what it does actually. So it increases vomiting, increase vertigo. You know what is vertigo? It's a kind of imbalance. Okay, loss of equilibrium. That is related to ear. So vomiting and vertigo. Okay, H1 receptors on CNS, what they do, they increase the wakefulness. Person is awake, not very sleepy, awake. And also increase, if the person is awake, it will be having good memory, but increase vomiting, like motion sickness, especially motion sickness and vertigo. So these are the H1 receptors. So H1 blockers, they suppress the CNS. If they suppress the CNS, person will sleep. And if they suppress the CNS, what will happen? Memory loss will be there. And but vomiting will decrease, that is motion sickness will decrease, and vertigo will also decrease, but person will sleep a lot. Okay, talking about H2 receptors, located in parietal cells. H2 receptors, these are located in parietal cells. H2 receptors, these are located in parietal cells. They are responsible for increased basal or hesial secretion. So they H2 receptor, they are located in the parietal cells. Parietal cells are responsible for increasing the hesial secretion. So if there is excessive hesial secretion, then what will happen? Peptic ulcer disease. So for the management of peptic ulcer disease, you have to block H2 receptor. H2 receptor blocker will decrease the peptic ulcer disease. Okay, HCl formation will be decreased. So which what are the drugs that block the H2? There are cimetidine, ranitidine, tidine, amine. These are all histamines. H3 receptor, these are located in presynaptic terminals, and they block both H1 and they reduce the H1 H2 receptors. Okay, H4 receptors present in WBCs, these are not very important, but try to remember these two. Let's talk about the beta histidine. Beta histidine is H1 agonist. Beta histidine is a H1 agonist. Beta histidine is a H1 agonist. Is it acting like H1 only? So it causes vasodilation. It is used in treatment of vertigo due to vasodilation of blood vessels related to vestibular apparatus. Contraindicated in asthma and peptic ulcer disease. Beta histidine must not be used. Asthma, because we know they cause allergy. Okay, H3 antagonism. H3 inverse antagonism means H3 antagonist. So what they do, they increase the histamine release in the presynaptic. So if H3 is there, histamine release will be increased in the presynaptic, and H1 will be binding here. Then CNS activation, useful for treatment of narcolepsy, and teprolicent is the drug for narcolepsy. So for narcolepsy, H3 inverse antagonist is used. So this is H3 inverse antagonist, means it is acting as H3 only. So actually I said that H3 what will do, H3 will suppress H1, but here we are using antagonist. So H3 will bind to the H1 and increase the CNS activation used in narcolepsy. Narcolepsy, I think you know from the CNS chapter. Tell me in the comment section. Let's be interactive. Tell me in the chat box what is narcolepsy. Okay, H3 agonism. H3 agonist means it will come by histamine release will decrease. So histamine will not be able to bind to H1 receptor. CNS will depress. So histamine release decreases. So improper CNS activation is there. Okay, now let's do. This is the beta histidine, which is using as which we are using at H1 agonist for the treatment of vertigo, because it causes vasodilation. Antihistamines. Let's talk about antihistamines. So antihistamines are important, guys. In exam in university, they ask like what are the antihistamines, classify them. Okay, antihistamines generally they are H1 blocker. Generally they block H1. Okay, they can cross the blood brain barrier. Okay, they can cross the let's do first generation. The first generation can cross the blood brain barrier. Second generation, they do not cross the blood brain barrier. First generation H1 blockage in series that cause sedation. I said that H1 will act on CNS and make it awake, so a person will be awake, but because of blocking, sedation will be there. But truck drivers must not be given these drugs, so never give the drivers or pilots these drugs. Okay, have antipsychotic property and responsible for nasal secretions. So they have anticholinergic property and responsible for nasal secretions. So nasal secretions will be decreased. So if you give antihistamines first generation, they will not cross sorry, they can cross blood brain barrier, they can cross blood brain barrier, so they will cause sedation and they will decrease the nasal secretions that is happening in allergy. Talking about second generation, they do not cross, so that's why no sedation. So this is the preferred drug for the drivers, and no anticholinergic property. No anticholinergic property. So special feature, additional anti-allergic mechanism. This is they have no anticholinergic activity, so they can be used as anti-allergic mechanism, and they are useful mainly for the allergies, you know, atopic rhinitis, allergic rhinitis, urticaria, cornea का भी रहता है ना, uveitis and all that. For that purpose they can be used. Okay, फर्स्ट जनरेशन एंटीहिस्टामिन से डिटेल में बात करते हैं. So all three have anticholinergic property. Dimenhydramine, diphenhydramine, and promethazine. Dimenhydrinate, and promethazine. They have the anticholinergic property, but second generation do not have anticholinergic. Let's revise. See, first generation they can cross blood-brain barrier, that's why there is sedation, and they also have anticholinergic property. Second generation no anticholinergic property, so they have special effect on the allergy. So the treatment for first generation, dimenhydrinate, and promethazine, and this is used for drug-induced Parkinson's disease, okay, Parkinsonism disease, okay, drug-induced Parkinsonism. Diphenhydramine, and promethazine, they can cross blood-brain barrier, and they can also be used for motion sickness, okay. Meclizine and buclizine, motion sickness, 1 to 2 hours before journey you have to give. This is the previous question in which they ask ki when you have to give motion sickness drugs, you have to give 1 to 2 hours before the journey, before the onset of the journey, okay, before going to the journey, not after 12 hours, not before 12 hours, okay. Doxylamine or pyroxine is vitamin B6, vitamin B6, that used for morning sickness. Morning sickness is first few months of pregnancy, because of the hormonal changes in the body, the mother has the morning sickness, okay. So doxylamine and pyroxine is usually given, okay. Thalidomide also given for morning sickness. Thalidomide is also given for morning sickness, but highly teratogenic in women, so that's why never give to them, because still limb deformity is there to the children, to the baby fetus, so never give thalidomide. Never give thalidomide. Never give thalidomide to the pregnant lady. In previous days they used to give in the phocomelia, that still limb deformity, okay, no limbs are formed for that babies, okay. Cinnarizine is vertigo management, cinnarizine, and hydroxyzine, phenyramine, and chlorpheniramine. Phenyramine for the allergy, chlorpheniramine cough and cold management. If you see the cough syrup, you will find chlorpheniramine, and chlorpheniramine is mildly sedative, okay, fine. Hydroxyzine is management of allergies. Other drugs which have antihistaminic properties are tricyclic amines, doxepin, topical usage for pruritus, okay, and typical antipsychotics, they have a antihistaminic property. Second generation, let's talk about second generation. So second generation is terfenadine and estimazole and terfenadine, known to produce QT prolongation, so that's why they are banned. But Avastin is still being used. Why QT prolongation is problematic? Because it can cause torsidis de pointis, severe disease, okay. Fexofenadine, treatment of allergy, so no QT prolongation is there. So fexofenadine is for treatment of allergy, so no QT prolongation with the fexofenadine, so it can be used. Cetirizine, levocetirizine, they are commonly used for allergic. They are not metabolized such in urine, so they are isomers. Cetirizine, levocetirizine are isomers of each other, okay. Loratadine and desloratadine. These are topical antihistamines. Are what? This, try to remember this, helpful in ENT and opthal. These are azilastine, olopatadine, and epinastine. Azilastine, epinastine. Nastin for years and that topical. Okay. Rupatadine has antiplatelet activating factor property. Rupatadine, Rupa, Rupa for platelet, Pa for platelet activating factor, antiplatelet activating factor property. Rupatadine, and topical antihistamine is lastine, and here epinastine. Okay, cetirizine and levocetirizine isomers of each other. They are not metabolized. They are excreted as such in urine, and they are used for allergic purpose. Cetirizine, levocetirizine, fexofenadine, treatment of allergy and no QT prolongation. Okay, terfenadine, esomeprazole, they are banned because of QT prolongation, and but as abastidine is still used, it should not also used. Active active metabolite conversion. So these are the things. So terfenadine is converted to fexofenadine. Fexofenadine is the active one. Hydroxyzine, cetirizine, lonatidine, and desloratadine. These are active active metabolite. So this is the active drug. But after the drug goes into your body, the form which is going to act and produce the benefits is by this part. Fexofenadine for terfenadine, fexofenadine. It is going to fix the problem. Okay, which problem? It is second generation allergy. Hydroxyzine, cetirizine, and loratadine. Okay, hydroxyzine for cetirizine, lonatidine, desloratadine. Let's talk about another important. We are done with histamines. Let's talk about serotonin, pharmacology, and migraine. This is very important, guys. Migraine is the very important. So talking about serotonin, what is serotonin? I said both are amines. So serotonin is also amine. Serotonin is also amine, and it is also. So I forgot to say how they are synthesized. So serotonin is synthesized from serotonin is also called 5-hydroxytryptamine because tryptamine means tryptophan. Tryptophan is which amino acid? Tryptophan amino acid. So tryptophan let me take a blank page. Okay, so there is a tryptophan is the amino acid is converted into 5-hydroxytryptophan. Okay, 5-hydroxytryptophan is converted to hydroxytryptamine. Okay, so here hydroxylase is the enzyme, and here decarboxylase is there. Okay, let me tell you how. Did you understood that? And now I have removed it. First tryptophan convert 5-hydroxytryptophan, so you know how an amino acid looks. This is the amino acid. COOH is there, NH2 is there, H is there, and here some variable group is there. Okay, so this is the amino acid. So this is the amino acid. So if you remove this one, it will become amine. Okay, it will become amine. So for removing this, we need carboxylase. Suppose this is histamine, this is histidine amino acid, then after carboxylation it will become histamine. Suppose if this is 5-hydroxytryptophan, after decarboxylation will become 5-hydroxytryptamine. Okay, so this is the synthesis. How they are degraded, it's another thing. Let's not go that much deep. Okay, fine. So let's talk about serotonin. Serotonin is 5-hydroxytryptamine. It acts on 7 receptors. It has 7 receptors, 5HT1 to 5HT7. Pharmacologically important are 5HT1, 5HT3, 5HT4. Okay, let's talk about 5HT3. All these, okay, all these receptors. No need not remember all. And we are going to discuss more about serotonin in the CNS and the GIT. So these are important, okay. Talking about 5HT1, drugs which can be used. 5HT1, a partial agonist. Agonist means same. Buciprone reduces 5HT release from presynaptic terminal. Treatment of anxiety. Buciprone, it's a partial agonist, so it reduces 5HT release from presynaptic terminal. So treatment of anxiety is there. No sedation and no abuse potential. Let's talk about this 5HT2, 5HT2A, 5HT2C. These are 5HT2A responsible for psychosis and hallucinations. 5HT2C for anorexia. Five HT2C, 5HT, 5HT2C, lorcaserin was used to treat obesity, now banned as it increases risk of cancer. Let's talk about the antagonist, okay. First let's talk about this one. 5HT2 blockers, that is antagonist. Atypical antipsychotics does not differentiate 5HT2A and 2C. ADR metabolic syndrome. And 5HT2 antagonist, 5HT1 agonist. These are flibanserin and treating female hyperactive sexual desire disorders, that is premenopausal. Female hypoactive sexual desire disorders. This premenopausal. Premenopausal, what happens? Female hypoactive. Okay. Let's talk about 5HT3. And also here 5HT1 BD agonist, which is important for migraine. They cause vasoconstriction. This is triptans. Triptans, they have side effects also. For ischemic heart disease, hypertension, we cannot give triptans, and the newer drugs we discuss. 5HT3 located in GIT. So 5HT3 is important for what? You know your favorite drugs. 5HT3 Sertans, ondansetron, cetrons, not cetrons. Ondansetron, 5HT3 antagonist. Ondansetron for nausea and vomiting. Granisetron, especially for chemotherapy induced vomiting. These are having the centers in the CT. These have the centers in the CTZ. Do you remember? CTZ is not having blood-brain barrier. CTZ have different receptors: NK1, CD2, NK1, D2 receptors, CB1 receptors, 5HT3 receptors. Discuss in detail in GIT. 5HT4, 5HT4 agonist have prokinetic property. Prokinetic means it will increase the motility and faster gastric emptying is there. These are mosapride and cisapride. They increase MI risk, hence they cannot be used now. And prucalopride treat IBS, irritable bowel disease, and constipation. It is longest acting 5HT4 agonist. Agonist are pride. All what we use are H1. The trick to remember is 5HT4 is the having pride. Okay, that's why it's pride. Precalopride. One more is there. One important one is missing from here. I'll tell in the GI. Okay, serotonin drugs, serotonergic drugs. So drugs which act on specific type of receptors. 5HT1A agonist, 5HT1BD agonist. This is for migraine. 5HT2C agonist. These 5HT4 agonist for prokinetic and antiemetic. Drugs which increase serotonin in synapse. Selective serotonin reuptake inhibitors. SNRI dysfunction and TCS. Okay, and this non-specific drugs: cyproheptadine, methylsergide, LSD, ergots. Okay, triptans. These are 5HT1B, 1D agonist, act on blood vessels, vasoconstriction. You know, triptans, they cause vasoconstriction and they release the pain of migraine. They are the first drug of choice for migraine, but now newer drugs are also available. So first drug which is widely used, sumatriptan. Orally bioavailability is only 15%, so subcutaneous is the drug of choice. Acute attacks of migraine, it is given for acute attacks. Both zolmitriptan, it's both drugs can be used as nasal spray. Advantages: when patient is at home and cannot come to hospital immediately, nasal sprays can be given. It's comfortable. Okay. Rizatriptan is fastest acting. Fravotriptan is long acting, and Alitriptan used for management of migraine attacks. Advantages: vasoconstricts blood vessels, decrease nausea, vomiting, decrease neurogenic and inflammators. So alitriptans are for management of migraine. They constrict the blood vessels, vasoconstrict the blood vessels, nausea and vomiting also decrease, and neurogenic inflammations also decrease. So 3 in 1. A note: 5HT1F agonist, lasmitinib, used for acute attack of migraine. Contraindications of triptans: ischemic heart disease, coronary artery disease in pregnancy. You cannot give pregnancy, never give. Applications: drug interactions. What are there? Patients with ergot and sumatriptan you should never give. Both can cause a severe vasoconstriction, and at least there should be 24 hours gap between the two drugs, ergot and sumatriptan. Okay, otherwise there will be gangrene, because severe vasoconstriction, no blood supply, gangrene, necrosis and all. No non-specific serotonergic drugs. So did you got about triptans? Triptans are 5H1, 5HT, that's a serotonin, 1BD agonist, the agonist. 5HT, 1B, 1D agonist. 5HT, 1B, 1D agonist. These are used for migraine. 1B, 1D agonist used for migraine, cause vasoconstriction. Non-specific serotonergic drugs. Non-specific serotonergic drugs: cyproheptadine, 5HT2 blocker major, H1 blocker, M blocker are used. Treatments: prophylaxis of migraine, off-label for weight gain in children, not officially approved. So cyproheptadine not used. Used for treatment of serotonin syndrome. Then there you can use cyproheptadine for serotonin syndrome. Methylsergide used for acute attack of migraine. Methylsergide ADR, the adverse drug reaction is fibrosis. So you cannot give LSD, hallucinogen, and abused by many. So never give LSD. Cyproheptadine side effect is also fibrosis. Talking about ergots. The question you get is classify ergots and mention the drugs. So have alpha blockade property. Action on uterus. On uterus, it contracts both upper and lower segment of uterus. So treatment of postpartum hemorrhage. contracting ischemic heart disease and hypertension patient. So these are used for contraction. Both upper and lower segment of uterus contracts. On blood vessels, vasoconstriction, treatment acute attack of migraine in ADR, and what the drug reaction is gangrene. So for that purpose, immediate administration of vasodilators, sodium nitroprusside should be given to prevent gangrene. Okay. Treatment of acute attack, ergotamine and dihydroergotamine. Drug used for PPH, postpartum hemorrhage, ergometrin and methyl ergometrin, but these are not nowadays used. We have mifepristone and misoprostol. We don't give this ergotamine and methyl ergometrin. Okay, don't give this drugs, ergometrin and methyl ergometrin. Don't use ergometrin, ergotamine, all this. So older drugs. Talking about pharmacology of migraine and then prostaglandins. Then coming to our favorite NSAIDs. After NSAIDs, COX and gout. So this long way. It will take time. It is going to take time. Already half an hour is done. I want to conclude it faster, so the session do not get boring. Okay. Pharmacology of migraine is acute attack is also there, chronic attack is there. For acute attack you give NSAIDs. What are NSAIDs? When I ask students NSAIDs, they get confused. NSAID का एक भी नाम ही नहीं. NSAID, indomethacin, diclofenac, sodium, all these. Okay, NSAIDs लिख के मत बोलो. Write the examples also. Indomethacin, cyclophenac, mefenamic acid, all that. IV metoclopramide for controlling nausea and vomiting, and ondansetron. IV ondansetron because the patient along with pain they get nausea and vomiting because CTZ is stimulated. So you can give ondansetron, metoclopramide. I don't recommend because they have side effects a lot. Sumatriptan, subcutaneous drug of choice. Always ask for drug history. If they have taken ergotamine, do not give sumatriptan. Okay, if they have already taken some drug and coming to you, never give, because there should be at least 24 hours gap. So extensive vasoconstriction, gangrene takes place. So to prevent sodium nitroprusside, immediately have to give. Okay. So talking about this now, CGRP antagonist. This is the new drug. So Eurogeptan, pant you have to run, remigepant and ubrogepant, okay, Gpant, remigepant, or remigepant, okay. 5 has T1F agonist, lasmitidine. These new drugs are there. You have to use this one. 5 has T1F agonist. Nowadays everyone is hypertensive and have a cerebral problem and ischemic heart attack and all. So lasmitidine nowadays tools used. Lasmitidine, 5-T1 F agonist, 5-T1 agonist. So chronic prophylaxis के लिए drugs, ABC drugs. Chronic prophylaxis, you have to give this amitriptyline and nortriptyline, onabotulinum toxin A, anti-epileptics, gabapentin, sodium valproate, topiramate, beta blockers, propranolol, timolol, metoprolol, candesartan, calcium channel blockers, L-type verapamil and T-type flunarizine, CGRP antagonist, and anubab once a month. This is the antibody actually. Anubab, IgG antibody. Okay, so chronic prophylaxis के लिए क्या दोगे आप? ट्राइसाइक्लिक का मीन्स क्या है? एमीट्रिप्टिलिन, नॉर्ट्रिप्टिलिन, ओनाबोtulinum toxin A, anti-epileptics, gabapentin, sodium valproate, topiramate and beta blockers में propranolol, timolol, metoprolol. candesartan, calcium channel blockers में L type देना है, N type देना है verapamil and T type में flunarizine. CGRP antagonist में erinubab और once a month देना है, हर महीने एक बार दे दो as a prophylaxis for chronic. Okay, acute attack के लिए you have to immediately give the NSAIDs. NSAIDs bendomethicillin dicyclophenolic mefenamic acid, you can give this one. And IV metoclopramide or ondansetron you can give for vomiting, and sumatriptan for subcutaneous drug, but never with ergotamine. Ergotamine dihydroergotamine ergotamine के साथ नहीं देना है. CGRP antagonist ubrogepant and remigepant. 5-HT1F agonist lasmiditan. 5-HT1 agonist lasmiditan. 5-HT1F agonist. 5-HT1F agonist lasmiditan. 5-HT1 agonist lasmiditan. NSAIDs देना है IV मेटोक्लोप्रामाइड या फिर बेस्ट ऑनसेट्रॉन दे दो. एंड सुमाट्रिप्टन के ऑलवेज आस्क द हिस्ट्री देन ओनली गिव. अगर एर्गोटामिन लेके है तो 24 आवर्स गैप मिनिमम रहना. Okay, and another is CGRP antagonist that are pants, that is remigepant and ubrogepant. 5-HT1 agonist के लिए lasmiditan. 5-HT1 agonist. एंड क्रॉनिक प्रोफाइलैक्सिस के लिए ट्राईसाइक्लिक अमीन्स दे सकते हो. कौन से हैं? एमीट्रिप्टिलिन और नॉरट्रिप्टिलिन. एमीट्रिप्टिलिन एंड नॉरट्रिप्टिलिन. एंड अनाबॉटुलिनम टॉक्सिन नहीं दे सकते हो बिकॉज वासोडाइलेशन. ओके, अनाबॉटुलिनम टॉक्सिन ए. एंटी एपिलेप्टिक गाबापेंटिन सोडियम वाल्प्रोएट एंड टोपिरामेट. gabapentin, sodium valproate, topiramate, these are the anti-epileptics you can give for prophylaxis of migraine. That is gabapentin, sodium valproate, topiramate. Gabapentin, sodium valproate, topiramate. Gabapentin, sodium valproate, topiramate. Topiramate, gabapentin, sodium valproate. Beta blockers, propranolol, timolol, metoprolol. Propranolol, timolol, metoprolol. And candesartan, you can give candesartan. And for calcium channel blockers, calcium channel L-type T-type is flunarizine. CGRP antagonist erinumab. Prostaglandins पे आते हैं. The session is already 37 minutes. ओके, लेट्स कर ही लेते हैं. चलो, तो प्रोस्टाग्लैंडिन प्रिपरेशन, दीज आर मेम्ब्रेन फॉस्फोलिपिड्स. आपको पता है अपनी मेम्ब्रेन जो है फॉस्फोलिपिड से बनी हुई है ना. फॉस्फोलिपिड से बनी हुई है. सो फॉस्फोलिपिड के जो रिसेप्टर्स हैं, अपनी मेम्ब्रेन के रिसेप्टर्स है ना, फॉस्फोलिपिड A2. ठीक है. उसके बाद यहाँ पे देखो आप, यहाँ पे कॉक्स एंड लॉक्स लिकोट्राइन्स है. ये कॉक्स है. कॉक्स में PG, प्रोस्टाग्लैंडिन G2, प्रोस्टाग्लैंडिन H2, लिकोट्राइन C4, D4, B4. ठीक है. ट्राई टू रिमेंबर दिस. C4, D4, B4, आइसोमेरेज, थ्रोम्बोक्सिनेज एंड प्रोस्टोसाइन. मैं ये अलग से ले लूँगी. हाँ, नॉट मेरा मुँह आई एम थर्स्टी. ओके, एनसेट्स देख लेते हैं. एनसेट्स इंपॉर्टेंट है, कॉक्स भी इंपॉर्टेंट है ना, तो ये भी नेक्स्ट क्लास में करें. अभी तो आपको फाइनली मैंने जो भी पढ़ाया है माइग्रेन के बारे में, ये अच्छे से देख लो. माइग्रेन क्या है? माइग्रेन एक्यूट हो सकता है, क्रॉनिक हो सकता है. माइग्रेन क्यों होता है? यू गाइस नो व्हाई माइग्रेन हैपेंस फर्स्ट ऑफ ऑल. So there is a neurogenic theory which says that this is supposed to be your brain, some area, and this is the artery, and this is the vein. Somehow there is a shunt is formed because of vasoconstriction. This is the artery I said. this is the vein. These are constricted because of constriction. The blood is not able, the blood is not flowing through it. This is blocked, blood is not flowing through it, and because of that there is a shunt is formed, and this shunt is dilated a lot. And because of that, here, because of, there is necrosis going on, and because of that there is release of the anti-inflammatory, sorry, release of the inflammatory substances. Because of release of inflammatory substances, there is a extensive throbbing pain. Okay, extensive throbbing pain. So because of extensive throbbing pain, we give the uh, triptans and NSAIDs and all anti-inflammatory, and vasoconstricting also to decrease the vasodilation of this atrioventricular shunt. Okay, AV shunt to decrease this. Okay, so these are the mechanism of migraine. So because the here artery is constricted, vein is constricted, the area of the brain is not getting blood, because of that it is getting necrosis. That's why it is releasing some inflammatory substances that causing extensive pain, and this is atrioventricular shunt is dilated a lot. Okay, so we give vasoconstriction like beta blockers, propranolol, metoprolol, all that. Okay, so try to remember the mechanism. So thank you so much. We'll continue next later. Thanks.